Okay, good morning. I would like to welcome you to today's residence lecture, which will be held by Dr. Stefanie Hill. Dr. Hill is a graduate from the University of Marburg in Germany and a third-year resident in our department, and her talk will be about the ever-growing topic of growing complexity, which is multimodal therapy in locally advanced rectal cancer. Please, Stefanie.
Thank you very much. Good morning, everyone, and thank you very much for the kind introduction and support, Professor Turina. Today I'm going to talk about the multimodal therapy strategies in locally advanced rectal cancer, and for we had a recent lecture on the surgical aspects. Today I'm going to focus on the perioperative therapy strategies. Looking at the content, I'm going to talk about epidemiology and anatomy real quick, then the staging of rectal cancer, and then we're going to jump right to the neoadjuvant therapy strategies, a rather new approach, which is the watch and wait strategy, the adjuvant therapy options, and then the as well new approach of the total neoadjuvant therapy. Looking at the epidemiology real quick, what we do see over the last recent years is that we have a decrease in the incident and mortality rates in older generations, talking about the ages 50 and plus, which is due to the introduction of the screening colonoscopy. Which is rather worrisome is that we do have a increase in the incidence rates between the ages 20 and 49, and that is believed to be due to environmental changes, just as a more sedentary lifestyle, as a higher intake of alcohol and meat consumption going along with a greater obesity. Yet I do have to say that the rates for cases are not comparable. Like if we look at the ages between 56 and 47 years old, we do have an incidence between 100 and 200, and comparing that to the younger ages, there's an incidence between 12 and 14 per 100,000 cases. Looking at the contribution, rectal cancer makes up almost 50% of all colorectal cancer patients, and the rest is divided into the other column parts. This is basically what I want to cover today, and especially neoadjuvant therapy for locally advanced rectal cancer can be very overwhelming because there are a bunch of therapy strategies that we have to look at, and especially for us younger residents, it can get quite overwhelming and confusing. Looking at the anatomy, the rectum is divided into three parts. We do have the lower rectum, the middle rectum, and the upper rectum, and that counts from the anal verge from 0 to 6 is lower rectum, from 6 to 12 centimeters is the middle rectum, and from 12 to 16 centimeters is the upper rectum. Historically seen, surgery and then adjuvant radiotherapy was the go-to approach for treating rectal cancer. But what we did see after surgery was that we had high reoccurrence rates, especially in the middle and lower rectum. And that's why neoadjuvant therapy was introduced, especially for masses in the lower and middle rectum. Looking at the tumors in the upper rectum, these are still treated because of the low reoccurrence rate. They're still treated like colon cancer with upfront surgery and then adjuvant therapy depending on the pathological outcome. How do we stage rectal cancer? It's very important to start with a clinical examination and a rigid rectoscopy, especially to measure the distance from the anal verge and to clarify the height of the tumor. A colonoscopy has to be performed to rule out a second tumor, and then endoscopic ultrasound and rectal MRI are very important to evaluate the T stage, the N stage, and the CRM, which is the circumferential resection margin, and translates anatomically to the mesorectal fascia. A CT abdomen and of the chest have to be performed to rule out distant mets, and CEA levels are monitored to check for or monitor the treatment and check for a relapse. Looking at the TNM classification real quick, locally advanced rectal cancer is defined by T3, T4, which means that T3 actually invades the subserosa through the muscularis propria, T4 invades the peritoneal reflection and other organs, and N+ is when we suspect the lymph node involvement. So just as a reminder, early stage cancer in the lower and middle rectum as T1, T2, and 0 is treated by surgery first as well. This is not what I'm going to talk about today. Today, we're going to look at the advanced stages, T3, T4, and N+. And this is what we do. We go to neoadjuvant therapy. And what do we expect from neoadjuvant therapy? We do expect a significant tumor regression, especially a downsizing in the primary tumor size, a decrease in the depth of penetration, and a nodal sterilization, which is called the downstaging. The ultimate goal or aim being the complete clinical response, which means the complete absence of any kind of tumor that could potentially lead to an organ preservation. The two possible options that our guidelines are recommending right now are the conventional radiochemotherapy, which consists out of 28 fractions of radiotherapy up to 50 gray, and then have a combined fluorouracil-based chemotherapy with surgery scheduled 6 to 8 weeks after. The second option is the short course radiotherapy that has a higher single fraction, which is 5 times 5 gray up to 25 gray. And then we can do immediate surgery within the next 10 days after radiotherapy, or, and this is what I'm going to explain to you a little later, do it with a longer period to surgery and have a delay of 4 to 8 weeks. Our guidelines do state these two options based on the results of a Polish trial of the Polish colorectal cancer study group. And they did compare the conventional radiochemotherapy plus surgery within 6 to 8 weeks versus the short-term radiotherapy and immediate surgery. And what they found was a better downsizing, a better pathological complete response rate of 16% versus just 1% in the short-term radiotherapy group. Although what they also saw was that the rate of sphincter-preserving surgeries was the same, and there was no significant difference in the local and systemic tumor control, as well as the long-term survival and late toxicity. So our guidelines do recommend that if a tumor shrinking is intended, if we have an advanced T4 tumor, if we have a close proximity of the tumor to the mesorectal fascia, we do recommend that we do conventional radiochemotherapy. Looking at the MRI, this shows like an advanced tumor, a T3 tumor with, and this is the yellow arrow showing, an infiltration of the mesorectal fascia, and therefore this patient would profit from a conventional radiochemotherapy. Now, what they saw in this trial and comparison, that if they had short-term radiotherapy and they had a longer period between administration of radiotherapy and surgery, they did have a better downsizing. So the question was raised whether the downsizing was just a matter of time. And what was done was a comparison between a short-term radiotherapy plus surgery within 7 days and a short-term radiotherapy plus surgery with a longer period of 4 to 8 weeks. And this is the Stockholm trial. Stockholm trial was published in the British Journal of Surgery in 2015. And it was a big trial, but what they did, part of it was they compared, like I just said, short course radiotherapy within surgery within a week, and then short course radiotherapy with a delayed surgery, and they looked at the pathological outcomes after the inclusion of 500 patients, looking at the TNN categories, the involved resection margins, and the tumor regression. And what they did say is rather interesting is that they had in the delay group, they had a significant difference in the tumor stage, the tumor category, the tumor regression, and had a complete pathological response in almost 12%, versus just 1.7% in the group that had surgery within a week. So our guidelines actually say that short course radiation can be used with the longer interval when downsizing is intended. And now, why do we look at short-term radiation? For smaller hospitals, it might be a challenge to actually have chemoradiation, which is like for 28 fractions in terms of capacity, in terms of the costs. And if we think about the patient, it's much easier for them to just have 5 fractions of radiotherapy, which is a shorter time than have an extended chemoradiation, and it is not to be underestimated. How do we assess the tumor response after neoadjuvant therapy? What we do is we do a digital rectal exam, endoscopy, and high-resolution MRI. The digital rectal exam, the result is usually, or is defined by a complete absence of any tumor, of any mass, of any stenosis that was there before. We usually feel just a flat scar with a very smooth surface, and the endoscopical results are usually a white scarring with telangiectasia, just as you can see on the lower picture on the left side, where we do see a complete clinical remission. This is the next pillar I want to talk about, which is the watch and wait strategy after clinical complete response after neoadjuvant therapy that is actually observed in trials up to 40%. So up to 40% of the patients that underwent neoadjuvant therapy do present with a complete clinical response. And what does that tell us? Imagine if you're the gastroenterologist, where like the patient comes to you for the checkup after neoadjuvant therapy, and you have to tell the patient, look, you had neoadjuvant therapy, it worked quite well, your tumor is gone. And then the patient tells you, listen, I'm 80 years old, I have a heart condition, I have an aortic valve, I take fenprocamone. Do I really need that surgery? Or even worse, you're the surgeon, you're doing a surgery which is recommended right now in this term. We do TME. And then the patient, that very same patient, has a post-op complication, has a lethal outcome, and then the patient is that, and then pathology comes back, and pathology tells you, well, you had a pathological complete response. And these issues are looked at and evaluated with the watch and wait strategy, that we could potentially spare patients an unnecessary resection that could aim for rectal preservation and an optimized quality of life. I want to introduce to you a trial that was done in New York by the Memorial Sloan Kettering Center. And what they did is they looked at 1,000 patients who underwent neoadjuvant therapy. 960 of them had the surgery, and around 13% had a complete pathological response. We're going to compare that group to a group of 113 patients who agreed to do the watch and wait surgery. They had an active surveillance but did not have further treatment. And around 81% of them, 91, sustained with a complete clinical response and went into the group of rectal preservation. 22 had local regrowths, and 2 of them were salvaged with local incisions, so they also count in the rectal preservation group, and 20 of them were salvaged with TME after being identified with local regrowth. What I do have to say is that these are the limitations of this trial, is basically that the patients who agreed to the watch and wait strategy were in a median 10 years older and had lower lying tumors. And they did not have the very same neoadjuvant regimen. So it's kind of hard to compare, but they did it anyways. And the results that they found was that the 5-year overall survival and the disease-free survival was around 20% less in the watch and wait group versus the group that had TME and then a pathological complete response. Yet they did say that they did have a high rate of rectal preservation, an effective surgical salvage, and excellent pelvic tumor control, which leads us to the statement that when we weigh the risks of a lower overall survival and or weighing the risks of the watch and wait strategy versus the benefits of organ preservation and quality of life, we do have to take caution. And I think what we need to do is find characteristics of patients that exclude them from a watch and wait strategy, so we can prevent local failure and distant progression. Our guidelines do not recommend watch and wait therapy outside of ongoing trials. Jump into the adjuvant chemotherapy. There's been a bunch of trials that compared adjuvant chemotherapy after the administration of neoadjuvant radiochemotherapy, and none of them showed a superiority for an adjuvant chemotherapy. This one shows 4 cycles of fluorescence-based chemotherapy were administered versus surveillance, and the 10-year survival was pretty much the same. So our S3 guidelines do not have a clear recommendation for adjuvant chemotherapy right now. Like I said, several other trials failed to improve disease-free survival or overall survival, and these trials were limited by a very poor compliance due to post-op complications and treatment-related effects, meaning that a patient who underwent neoadjuvant radiochemotherapy then had surgery, and now they're supposed to have chemotherapy. They were done. They were tired, and due to the complications, they all basically present with very poor compliance. With the introduction of neoadjuvant therapy, what we do see is we have less local reoccurrences, but we do have more distant recurrences. So the question was raised whether we should assess pre-operative rather than adjuvant chemotherapy. And this is the new approach. This is the total neoadjuvant chemotherapy. And I want to introduce to you a randomized phase 2 trial of the German colorectal cancer study group. And what they did is they randomized patients into two groups. Group A received induction chemotherapy with 3 cycles of FOLFOX, and then had the conventional chemoradiation therapy, had a short break, and then they had surgery, versus a group who started with the conventional chemoradiation, then had a consolidation chemotherapy with 3 cycles of FOLFOX, and then went to surgery. And they wanted to look at the pathological complete responses that they had and compare them basically to the 50% that we have after standard conventional chemoradiation. And what they did see in group A, the group that had the induction chemotherapy, it was about the same. The PCR was 17, but they did see an increased PCR in the group that had the consolidation chemotherapy. Yet, I do have to say that the compliance was better in the modality used first. So basically, for the induction chemotherapy, the compliance was better than in group B for the consolidation chemotherapy. And this might actually change the later outcome if we follow up. We do know that a better PCR translates or is a good prognostic factor, but we do yet have to see if it actually translates into improved oncological outcome. The idea is, though, of total neoadjuvant therapy that we could use the different TNT sequences. So whether we do consolidation chemotherapy after conventional radiation, or we do an induction chemotherapy to treat the different subgroups of patient. And for example, group A with the induction chemotherapy, with the early introduction of early systemic therapy, we could address micrometastatic disease just as in patients that are staged with N+. Whereas group B, where we do have the chemo radiation therapy first, we could actually use that for patients who have locally advanced in terms of like a deep tumor death, a T4 tumor, or low-lying tumors, to actually enable curative resections and avoid abdominal perineal sections in general. Yet we do not have a 5-year follow-up yet for these studies, and it's going to be very interesting to see what happens over the next 5 to 10 years. I want to end my presentation today with a couple of conclusions, a couple of take-home messages. The conventional chemoradiation is equivalent to the short-term radiation. Both are based on our guidelines, and the short-term radiation with delayed surgery, the 4 to 8 weeks, can be used for downsizing as well. The watch and wait strategy is not recommended in our outside of clinical trials. And we do have conflicting evidence on adjuvant chemotherapy after neoadjuvant chemoradiotherapy is administered. And TNT, the total neoadjuvant therapy, the new approach, we do yet have to establish an optimal scheduling of having chemotherapy as a consolidation or an induction, and we do need to figure out the best sequences for each patient. The key to simplifying the management of rectal cancer, and this is very important, is the clear understanding of the presenting stage. When we stage the cancer, when we stage the patients, we do need to know whether it's an early or whether it's an advanced stage, especially locally speaking, and if the location is high or low. And then the management of rectal cancer can be quite simple. I don't know if that's the word, but we do have good management strategies. Thank you very much for your attention.
Stephanie, thank you very much. Excellent presentation. I learned a lot here, and you very nicely showed that this is always a bit complex. It's not just chemotherapy and look at complications, but compliance, and maybe the aspect may also by age may also be important, the compliance from one age to the other one. You also very showed that we still have a lot of questions that need to be addressed, and we learn a lot through randomized controlled trial. And I think we're very happy that some country and some group are able to answer this question. RCT answer only one question, but they are important questions, and it takes time until we have the answer. Maybe one question that for you or for Professor Turina here is, when you have this rectal cancer concomitantly with liver metastasis, we discussed that, this is frequent in that, and let's say this is not highly symptomatic in this situation, what would you recommend? The neoadjuvant, then liver surgery? What is you, and how would you stratify this?
Thank you very much. This topic was deliberately not covered in this presentation because we believe this to be complex enough already. But in general, we follow the principal recommendations that are published for synchronous liver metastasis, in the sense that we address the primary tumor first. If the primary tumor is symptomatic, meaning it is either obstructing or bleeding. If this is not the case, we definitely choose to start with chemotherapy first and then address the problems one after the other. The debate has been revolving around the synchronous treatment of colorectal liver metastasis along with the resection of the primary, and I think that's an ongoing debate. We still don't know which patient qualifies for simultaneous resection of both metastases and primary cancers. And I think there is a very broad area where individual decision-making is still the way to go. Yeah. But from my side also, thank you very much. It's been a very scholarly presentation altogether, a rather complex topic. And maybe from my side, I think that's one of the major problems that we have now, is the treatment of low rectal cancer has become so complex. And we live in an era where we try to explain our treatments to patients, and sometimes it just becomes way too hard for patients to follow the treatment that we will have to put them through. And there is actually a risk that we are losing patients by simply becoming too complex. When you try to explain this to a patient in your clinic, patients will just not understand what you're telling them. And so one of the solutions to this problem that we have tried to use now is to start a outpatient clinic together with radio-oncologists and the oncologists, where we try to address all these questions in the first round with the patient. That does not solve the complexity, but we've made good experiences in that we just try to make things easier for the patient. Otherwise, we've had it happen that we explain this to patients, and they will walk to another hospital where somebody will tell them, hey, we've got a much easier solution for you. You just come next week and we'll do an operation and you're rid of your problem. And you're actually at risk of losing patients. So I think that's one of the issues. Any other questions?
Yes, thank you very much. It was excellent. I have a question about the watch and wait strategy, because you say you would not recommend it outside of a clinical trial, but we still do it. And when do you do this?
Maybe I'll have to answer that. The German S3 guideline says do not do it outside of trials. The American guidelines, they are somewhat similar. But at the end, as you know, in multidisciplinary tumor conferences, the final decision is still an individual one that is based upon the individual patient. And so we have decided to enter patients into a watch and wait rationale when they have a low-lying rectal cancer, lower third, that is a T3, N0 or N1. These patients, in our opinion, are the ones who qualify best for a watch and wait therapy. But we talked to them, we informed them about the somewhat experimental nature of this, of watch and wait. And we always give them the option to opt out or to go straight to surgery. It is not something that we advocate to patients because we just simply cannot do that with the current guidelines. But we want to have an offer to patients, and we want to be able, as a department, to include this in our regimen of therapies for rectal cancer. So we use it, but we're very careful. The bigger problem actually is that patients nowadays, as you well know, they will start doing their Google search and they will come up with watch and wait themselves. And we have a number of patients who come to us now and they say, hey, my tumor is almost gone, let's do watch and wait. And you say, no, this you do not qualify for watch and wait. And they will tell you, hey, I've been through chemoradiation, I'm doing so much better, I don't feel anything. You barely can see anything on the MRI. Why should I do surgery? And that's a very difficult discussion. It's a very difficult discussion for the very reasons that Stephanie has shown us. And sometimes we do an operation where we convince the patients to do an operation and they're a pathologic complete response. So the patient was right. But we still have to operate on them because they just do not fall into the category of watch and wait. But that in some instances is difficult. And we've had several patients who have decided to do watch and wait on their own by simply not following through with what we recommend, and they will end up having bad recurrences. So it's risky. It is risky. And I think the only thing you can do is be open to your patients and spend a lot of time talking to them. And that's really what we have to do.
Excellent talk, thank you. I would just also like to add something to this watch and wait strategy. I think for highly selected patients, it seems very attractive to do this watch and wait strategy. However, two aspects is that first, we have a lot of follow-ups that the patient is coming back to our clinic and has regular endoscopies, MRIs, which is sometimes demanding for the patient as well. And on top of that, the psychological aspect is another important topic as well. Patients, they know they somehow they still have their tumor inside and they need to cope with that, and sometimes that is very stressful for the patient as well, and the operation is sometimes relieving the patient after that. That's another aspect that needs to be highlighted as well.
Did you come across that in your preparations? Very much so. Yeah. We actually had a patient who came to us who introduced himself into watch and wait, and we said, no, we need to do an operation. You do not qualify for watch and wait. But this was an academic person, and he said, hey, I made this decision, I will not be operated. And so he went into watch and wait. And he was free of tumor all the way up to 4 years. And after 4 years, psychologically, he was so stressed by his watch and wait. He came to us and he says, hey, I cannot take this any longer. Please take out my rectum. But then we said, hey, you're at 4 years and you're still free of tumor. We did not agree in the very beginning, but now you're at 4 years and they're free of tumor. We cannot take out the rectum now. So we left the rectum in, and he's at 6 years now, and he's still free of tumor. But the psychological burden of following through with examinations every 3 months, literally for 5 years, that's a tough burden for many patients. And so some of them will just not, follow this through, and they decide, no, I have enough of this. Please take out the rectum.
If you have patients in the watchful waiting group, you screen them every 3 months, regardless 5 years, 6 years.
No, for the first 3 years, we see them every 3 months, and then we see them every 6 months. But especially during the first 2 years, they get MRIs, CT scans, endoscopies every 3 months. And so they go from one exam to the next. They just keep going from exam to exam to exam. And why do we have to do that? Because in the original Haber-Gamma group of patients, there was a 7% group of patients from the initial complete responses that went into recurrence and came too late for salvage. So they were introduced into watch and wait, and they could not be salvaged in the end. And that's almost 10%. So that's a lot. And so we're just afraid of these patients, that we end up having recurrences that we cannot treat early enough. Okay, if there's no more questions, thank you very much.
Very much.
Stephanie, very well done.